Hello, everyone. Welcome. My name is Vicky Cloney, and I work for a third sector organisation in the west of Scotland. I know I don't sound like I'm from the west of Scotland, but I'm married a Scotsman. So I hope you had a lovely lunch, got a chance to get outside for some fresh air. And this afternoon, we're going to be talking about cross-sectoral collaboration. So our first presentation today is by Grace and Brianna from Ontario Health. Ladies, would you like to come up, please?
All right, good morning, everyone. Grace and I are very excited to be able to speak with you all today about some of our work with Ontario Health teams. Today we'll be talking about a patient-focused integrated data dictionary and repository and walking through the process towards data integration into Ontario Health teams that traditionally have had a more siloed data collection and data sharing.
Both Brianna and I are postdoctoral research fellows with the Institute of Health Policy Management and Evaluation at University of Toronto, and we worked as embedded OHT fellows this year. We have nothing further to disclose. We will begin today with a brief background about Ontario Health teams, which are sometimes referred to as OHTs or OATs. We'll give some information as to why data integration is important in the context of OHTs, delve into our actual data dictionary process, explore some of our lessons learned, and look at key enablers in the process, and then discuss some of the next steps around the repository, dashboard, and how to spread and scale with a toolkit.
So first, we want to just give you a brief overview of Ontario Health teams. They're a newer model of care, of integrated care in Ontario, Canada, that were developed to provide a new way of organizing and delivering care. So OHTs bring together various partner organizations across sectors, so primary healthcare, acute, home care, long-term care, mental health and addictions, community service providers, and also local regions and municipalities. There are currently 54 Ontario Health teams in the province, with the first round or cohort of applications being approved in 2019. So now there's a total of 4 cohorts in varying stages of maturity. The objectives of OHTs is centered around the quadruple aim of integrated care, which most of us are familiar with, that has that population health management at its core. So the population health management approach, I think we're on the wrong slide.
Oh, no, that's just the next one.
Oh, okay. The population health management approach aims to provide better quality and more equitable patient and population health through the proactive management of health, focusing on non-medical determinants of health, using an equity lens, and addressing barriers to care. And then finally, focusing on all individuals of the community, both users and non-users of the healthcare system, in an upstream preventative lens, which was probably one of the bigger shifts for healthcare providers and organizations in Ontario. Other aspects of the quadruple aim are that patient experience, provider experience, and then providing cost-effective and efficient care. So in achieving these goals, OHTs have their attributed population, which in Ontario is based on where a patient is accessing care in the communities, as well as their other geographical and regional populations. So we worked within 2 different OHTs. The Barrie and Area OHT was a cohort 3, so a newer cohort that has an attributed population of 192,665. And then Grace worked with the Northumberland OHT, which has an attributed population of 51,124, and was a cohort 1. So OHTs have various needs depending on their cohort and the level of maturity, but for many there are common goals and associated challenges that exist. So for example, all OHTs have the mandate and the desire to engage in population health management, but in order to do this, you really need to grasp the complexities of your population and engage in segmentation, or separating your population into distinct groups based on the specific health needs. Although initial segmentation can be done with higher level data sorts, so our various provincial databases, census data, for example, ultimately OHTs really need to tap into their local data to delve deeper and identify or better understand their priority populations in a meaningful way to direct their work. So although segmentation and other components of this work are key, OHTs face the challenge of required evaluation, quality improvement research, and health literacy capacity at the local level, which can often be a challenge. Finally, OHTs are mandated to partner with organizations across numerous sectors. So in many cases, these sectors and organizations have not partnered before, making the goal of data integration a large undertaking, which is further challenged by local data availability and avoiding duplication. So central to the intersection of these goals and barriers is really data. So supporting data capacity by developing a dynamic mechanism to understand what OHT partners are currently measuring and collecting and identifying data gaps is a paramount. So giving rise to the data dictionary process. So the data dictionary is essentially a comprehensive guide for OHTs on their local data that helps build their capacity to achieve their goals in a more rapid way and is the first of many steps towards data integration.
So we began our quest to develop a community-informed data dictionary by reviewing the literature. And what we really found was a gap in information specifically on data integration in the integrated health space. What we did find was a predominant amount of literature on the computer science area. We did find in reviewing the literature the Minkman model of integrated care, and we found this to be helpful really to frame our data development initiative from an integrated care perspective. It helped us conceptualize all of the dimensions of integrated care and consider how data initiatives could support and even connect some of these different concepts and dimensions. We also examined other regional approaches to both merging data sets among various partners and also approaches to selecting measures for key performance indicators and adapted these into our approach. Finally, we refined and confirmed our data development trajectory in consultation and collaboration with various stakeholders. And ultimately, the work on the previous slide led us to develop and venture into the data dictionary process shown here. We use this roadmap as a visual representation of the process of data integration, moving from an initial data dictionary or index of data points through to a data repository or shared data platform, and finally to a data dashboard or live data tool. And because we are reporting from two different OHTs, as Brianna mentioned, there existed some variability based on different levels of maturity and readiness between our OHTs. This meant that each of our OHTs made it to different steps on the roadmap shown on the slide. Now, going through the different steps, we started off by engaging OHT partners. And the goal here was really to establish trust and a working relationship with the leadership and data contacts at each of the organizations to create buy-in in the data dictionary process. This proved to be the most time-consuming step, but also absolutely essential in the process. Next was to formally identify the current state of data collection within each of the organizations that we were working with, and also understanding the goals within each of these organizations when it came to data development and data collection. This allowed us to understand how they could be integrated into the larger OHT data dictionary. Now, by data, we're talking about routinely collected indicators, both for internal and external use. The third step involved actually receiving the indicators from partner organizations. Now, what we found was that there could be great variability in the indicators we were receiving, both in volume and type of indicator. For example, some of the organizations didn't have an established indicator list and instead sent us some summary reports to extract some of their data from, whereas other organizations routinely collected thousands of indicators and already had established their own internal data dictionary. The next step was actually to synthesize these collected indicators into a more concise list that aligned with the strategic priorities and priority populations within the OHT. This allowed us to have a more manageable amount of indicators to work with. And step 5 was actually synthesizing the indicators, then moving on to refining and extracting a select number of indicators from the data dictionary that would be used for the data repository. This involved a lot of stakeholder collaboration within the OHT.
The next step involved transferring the data from collaborating partners onto the shared repository platform. So this involved data sharing agreements, privacy considerations, and requires consistent, timely updating of the aggregate data. In terms of the data dashboard indicator selection, the key performance indicators selected for the repository were then further refined so that we had a handful of indicators that were meaningful to the OHT that were flagged so that they could have, and that they could have regular access to, and it really involved extensive stakeholder involvement and collaboration. While the data dictionary represents the most robust overview of the data, it's the dashboard that had the highly specified set of indicators that were frequently monitored and refreshed for live tracking and ease of access for the OHT. And after moving through the selection process for the data dashboard indicators from the repository, there was a digital platform that hosts the data dashboard. So to keep up with the shifting and evolving strategic priorities of the OHT, which in Ontario are frequent and numerous as they shift and adapt to the population, continuous engagement is needed to allow for an iterative adjustment to both the repository and the dashboard. And then finally, the ultimate hope is that the data provided in all three components, the dictionary, the repository, and the dashboard, will encourage evidence-informed decision-making and data integration to transform OHT priority setting. So in terms of lessons learned, from my perspective in a cohort 3 OHT, there were some key ones. So the first was being able to help the OHT understand commonalities and differences between various metrics in order to move towards that eventual integration. So although some organizations collected similar indicators, definitions of parameters really differed. So it was through the data dictionary that we started to come together and allowed the organizations to start speaking a common language and understand where the gaps were locally. Another lesson learned is that there really needs to be some separate pathways that are developed that align with the OHT's strategic direction and priority populations in order to help the working groups identify local data more readily. And then finally, getting patient and family and caregiver, clinician, and leadership involvement and perspective to help drive the key performance indicator work was identified early on as imperative and also proved to be somewhat of a barrier as well due to resource and expertise challenges.
And from my perspective within my OHT, I really found the variability in both topic and detail of the health indicators collected revealed the need for an equally adaptive data collection tool for integration. And I also found that the collective inputs really afforded the OHT an enhanced understanding of the various strategic directions of all of the organizations they were working with to help inform the strategic direction of the OHT as a whole. The next steps for this particular partnered project of Barrie and Northumberland OHT will involve the development of a knowledge translation toolkit to allow for other OHTs to learn from the work we have done and spread and scale across OHTs. And this will involve a lot of continued engagement with our OHTs to help build capacity. As final takeaways, we really found that the data dictionary process could be a key enabler in helping the OHTs achieve their goals of population health management and priority population initiatives. We also found that this process really does evolve as the OHTs mature, and it's an iterative, dynamic process that will help OHTs achieve some form of integration and connection that has yet to be realized across partners.
So a big thank you to our Ontario health teams that participated and to our faculty and staff at IHPME for their support. Thank you.
Thank you. Is the mic working okay? Thank you to the two of you for an incredible presentation. I'm Canadian and from Ontario and incredibly proud that you have held space with us today to share the work you are doing in your local Ontario health teams. And as we come together in shared purpose in this conference, it is not only so we can learn from each other, but that we can help build capability together so that we have even greater impact, collective impact. Vicki and I are co-chairing this session today. I'm Jodine Goldhar, and I'm from the International Foundation for Integrated Care. I'm lucky enough to be the vice chair of the board. And Vicki?
I'm the partnership facilitator with a third sector organization called CVS Inverclyde in the west of Scotland.
Wonderful. For everybody in the room, we are going to take questions at the end, but also on the app, there's a Q&A section, so please send in your questions, and we will be tracking them, and then at the end of the session, we'll be able to ask questions of all the presenters. It's wonderful to see everyone today.
Thank you so much. Excellent. So our next presentation is from Bart, and he'll be speaking about enabling integrated care through total workspace innovation. Thank you so much, Bart.
Thank you. Good afternoon, ladies and gentlemen. I'm glad to be here. It's a difficult hour in Flemish to fall asleep, so I'll try to keep you awake. So I'm glad to present you a case study of enabled integrated care through total workspace innovation in our organization. And Familiehulp is already born in 1949, so next year we will celebrate our 75th anniversary. And it's a large organization, as you can see, with more than 30,000 employees, 93,000 customers, more than 10 million hours of care, 8 training centers, 16 regional offices, 14 nurseries, also a huge department of cleaning service, and last but not least, we are also active in local service economy. Here you see our map, and you see the beautiful city of Antwerp in the middle. So I've promised my colleague to see, please visit Antwerp. It's such a beautiful city. So, done, check. Voila. We all know that we live in a VUCA world. It's well known, it's complex, it's volatile, it's ambiguous, it's uncertain. And your employees, yeah, that's difficult for them because it's not predictable. And it's also the situational, it's always changing all the time. So Familiehulp was with such a huge amount of employees, we are a huge tanker. And this is already mentioned in this morning, a lot of silos. And the question was, how can we work together on close continuity of care? Okay, I'm sorry. That's well known. Also, it's already said the integrated care. The question was in our organization, how will we can manage that by ourselves, that we can do that already in our own organization, how it looks like, before you go to another person. It's an interesting. And therefore, we used 5 important principles. Principles of what we called innovative work organization. First of all, you have in your own organization a shared vision with a lot of trust that is very clearly defined and that all employee knows that vision. Second of all, it's client-centered, it's quite obvious. All our processes started from the beginning, from the client. 3, also, as easy as possible, what everybody learns is that process must be lean, and you have to try all the time reduce complexity in your own organization. Go it away. 4, important principle is that each employee is independent and responsible for what he or she is doing. And 5th is a strong self-organizing teams. We work together with a consultancy, it's Prepared Mind, and they use sort of a temple. And what you have to know is that we take a lot of time thinking about governance, about structure, but it's culture, people, systems are even more important than your structure, than your governance. So also with leadership, mission, vision, and strategy, and then the results will come. We used a very nice methodology. It's called the mobilizing organization based on whole-scale change principles. And it's already a book that exists a long time, several years ago. It's Dan Miller. You have to have, for change, first of all, you have to have a common ground for change. When there is no sense of urgency, you will get no change. Second, even important, is that change is in the method. You are changing all the time and try to learn people what is happening with themselves. Learn during the change. Third of all, a dialogue. And fourth, 3 important components is, first of all, vision. Second, there must be a dissatisfaction of the situation. Employees must think, it's not so nice here. It's difficult to handle what we are doing. Our patient is not happy, so we have to do something. 3, there must be already first steps towards the new vision in your own organization. In Dutch, I called very nice word, fikkie stoken. It's called the little campfires. It's called the early adopters who really believe in the change. And those 3 components must be greater than the resistance against the change. So we started already several years ago, and it's all written down in a nice book published last year. And it was, first of all, was combine a consistent image with local diversity. Because Antwerp, also we live in a very small country with a complex organization, especially in health and welfare. But from Ostende to the eastern part, it's different. So the question was, how can we combine a consistent image with local diversity to better connect to local ecosystems? And 3, increase local ownership and autonomy. Our old structure is a well-known structure of very hierarchical organization structure. Top down, with senior management, with interregional management, regional management, middle management, a lot of management. At the right side, the central support systems, and also with, at the floor, local teams, but they are not know what each other does. So that's the reason why there's a high change of disturbance with low regulation power. So the design process was from a design within boundaries of the regional structure. That was our important start, followed the traditional design sequence. And you see that in that figure. You have your vision and the strategy. At the left side, you have the process mapping. You have to think about your primary care processes from beginning of the help just until the end. And to think in process mapping, starting from macro niveau to micro, from macro to micro. Think about production, think about support, think about control and coordination. We work together with several employees in several layers of our own organization, and we worked with local design teams and also with a global design team. And we did a lot of prototyping experiments. And this is what I already mentioned, that we know that already, there is a complex interaction network. And before, in an old structure, everybody was working next to each other. Teams who are shadowing and intake processes, there are teams who are giving the care, and the support team often doesn't know what is happening on the floor. So the solution was, how can we get into a more streamlined organization? And that's our new model. You see the client is centered, we give caring and domestic help close to the client. There are multidisciplinary teams around the client, less shredded, it's integral and also integrated, and the coordinated care is around the common client responsible for monitoring healthcare goals. The ideal is 8 to 12 people. Important switch was from individual to more that team members are interdependent. And it's nice to know and need to know that that's not going so easy as you think, because each employee does doing his own thing, especially when they are doing things at home, but it's their client. So how can we manage that in interdisciplinary teams? Team is recognizable. The team has a maximum of autonomy. Members fulfill star roles, and the star roles were especially those roles who most of the times are laying within the leaders of the team. For example, planning, the employees does their planning by their own, not the leader is doing the planning. And so they evolve from executive to self-organizing teams. So we have nice films on YouTube, but I will send them later on. And this is a sort of a customer journey within Familiehulp. There are more than 15 focus groups with mixed composition, in which it was considered which tasks can be laid deeper in the organization. And that's all about star roles. What can they do about their talents and their things that they are very proud and good in? It results in policy recommendation. There was our executive committee who gives green lights to go further on. And last but not least, and it's good to know that It's not that the teams are self-organized, that it went by themselves. There must be what we call working frameworks. So it's every employee develops leadership. We have several training programs. Each employee gets training programs in leadership. What can they do then by their own? And so more responsibility in developing. The leadership we really believe lies in the teams at all levels. And so you get more a culture of collaboration. The result was also that more leadership among our employees were also translated in more initiative, creative, and innovation. And therefore, and especially nowadays, there is in our country a really war of talent. So it's difficult to find employees. We really are convinced that in this way, that's the way we think that there are richer and more interesting jobs for the employees with high motivation and so on. So the talents of our employees and more team orientation with employees who rely on each other, more customer focus, more flexibility and agility. And that's why we think that for us it's more easy to cooperate and to work together with other organizations or individual caregivers, because they are convinced that those principles are nice to know and good to know. So we are definitely a learning organization. It's a learning process, as I mentioned already before, but nice to know for the leaders and the manager in this room, taking responsibility requires lasting impulses. You have to continue. We have chosen for formal leadership too. Leadership is transformational, steering remains important. So it remains necessary to make our governance and organizational structure more horizontal, and the coordination between the operational floor and also the support, how the interaction is very, you have to think about it, how you can manage that. So good things, last lessons, take time, take your time. Education is the most powerful weapon we can use to change the world. Mandela told that already several years ago. Well, we give a lot of training programs, not only about leadership, also about communication skills. How you can communicate with each other, because when you are interdependent, that's Flemish people does really try to talk to each other and to say, okay, what's really is happening all the time. Also, we give a lot of, our vision was also solution focused, and that was a very good method to train people and to empower them. Last but not least, and that's not my quote, within Familiehulp, we have more than 70 years of experience with compartmentalization. That's why we don't believe it anymore. And the best care is self-organizing care that grows from customers based on trust, based on consultation, and based on cooperation. Thank you for your attention.
Thank you so much, Bart. I loved the little campfires for the early adopters. However, I think your final quote about the, yeah, that's the one. That's the one. Excellent. So next we'll be hearing from Gillian Street on the HOP project.
Five minutes? Okay, thanks. And the clicker is that one. Okay. Hi, everybody. I've come to tell you a story about the most amazing project I have ever worked on in my life. I haven't got time to tell you the whole story, so I'm going to give you a couple of links at the end to some very comprehensive reports if anybody is interested. This was a pilot program run in Western Australia. Just to start with an example of one of the settings, we had 29 organisations involved in a program that had a very, very short time frame to implement it. It seemed like mission impossible, but somehow it all came together. And one of the locations was in, sorry, this video jumps a little bit at the part because it was just taken by somebody's phone. Davis Park is in Beaconsfield. It was previously known as the Beaky Bronx. This was a Friday during the HOP program. On other days of the week, you would be more likely to see groups of people drinking lots, fighting, dealing drugs. The police would come and go. And 2 organisations were already engaged at Davis Park. One of them had this street doctor van. That was a medical organisation. I think they might be running towards the van in a minute. Can you see the van? That's a van that goes and parks in various parks where people are afraid to access mainstream services. Imagined Futures also used to run a sausage sizzle there every Friday, and it was a time of engagement, but this was during the HOP program, so it's a little bit different. When I first read this quote, my first response was to say, well, everybody. And then I thought about it a little bit further and thought, well, not everybody, even in Australia, is offered care. There are a lot of barriers, there are resistance, there are various reasons, resources. I'm sure you can all think of risks or perhaps perceived risks that not everybody is able to access them. I also looked at care. What do they mean by care? Does care mean that you provide medicine for everybody who gets sick? Or are we going to go a step further and actually try and prevent people from getting sick in the first place? Also, what is meant by access? Do we build a medical centre and next door we can be running Pilates classes? Is that access? How many people here have worked with marginalised populations? They don't run towards mainstream services very often, do they? Well, not in our experience. Oh, sorry, I'm pressing the wrong button. So I'm just going to skim through this because everybody always wants to know who paid for all of this. Essentially, I'll just zip through. The Australian government essentially funded the HOP program, but it went through the West Australian Primary Health Alliance. Does everybody know where Australia is? Okay. And the City of Cockburn and WAFA, which is the West Australian Primary Health Alliance, had together been funding the Cockburn Healthy Lifestyle for a number of years. This had evolved over, over 10 years altogether. And this had become quite a success and people were talking about it. So WAFA decided that they would give Cockburn Integrated Health funds to see whether it would work in other local governments. But there were some challenges. If you just start at the bottom in the city of Cockburn, that had taken 10 years to evolve. There'd been a lot of time building up relationships with other organisations. We were given 9 months to form the partnerships, plan the project, implement the project, and evaluate the project. I actually wrote the report as a volunteer after it was finished. The only way we could do this was to engage people who had already spent the time building up trust with these organisations. And our partners consisted of 3 levels of government. There were medical and allied health organisations. There were a range of not-for-profit organisations and charities dealing with mental health issues, homelessness, poverty, aged care. Vulnerable can be a very broad term, and essentially we were providing these programs for anybody who was on benefits. That was our criteria for joining in. And that last one was 3 universities also took part, and we were able to have final year and master's prac students in a number of different departments helping. How we did it, we spoke to everyone we knew who might know someone we should know, and I started off with one-on-one interviews, and that's not me, unfortunately. I always wish I had hair like that. And we conducted a mapping exercise to see what services people could offer and also what they needed. We came up with a rough draft of how we thought a participant journey could work, and then we held a workshop. I'll just get some water. It was essential that the workshop had key decision makers there. We didn't have the time to have officers come back, go back to their CEOs, wait for a reply. We had to be able to get the plan running immediately. And we were amazed that 22 of the 29 organisations did send their top person. So that was a great success. Sorry, that was just the detail of the map, but I don't have time to go into all of it. I will just mention that we did have a few logistical issues along the way, and some of them were legal, some of them were just logistical, but we soldiered on. In order to help everybody come together, we asked all the organisations to send in a kind of bio about their organisation, and we put together this booklet that we distributed at the workshop, and there were in fact some solutions that were found there and then where people had gaps that could be filled by people that they read about in the booklet and went, oh, we didn't know that you did that. So it was a great networking opportunity. I really didn't want to answer the phone saying Cockburn Healthy Lifestyles Outreach Program for Fremantle and Melville, hello. And I was very relieved that they all voted for the HOP, which was suggested actually by one of the students that had come along, which incidentally stood for Healthy Outreach Program, but they said they chose it because it had an energetic feel to it. We also, and this term I did borrow, I have to acknowledge Anne Mills from the Isle of Man Hospice for coming up with the term the Coalition of the Willing, because I borrowed it from her. You may know that if people commit to doing something and they sign something publicly, they're more likely to follow through. So we got them to sign the Coalition of the Willing. Can everybody read that? And we got some really good input from the workshop. One of them was that we should offer different levels. So, for example, anything at Davis Park would be hop to good because there was no commitment. We didn't take any, they didn't do pre and post health forms or anything like that. They did have to, just from our duty of care point of view, at least from my CEO's legal advice, we had to get them to sign a waiver that they wouldn't sue us if they hurt themselves while they were exercising. So we introduced the HOP levels. I've passed around a few of our little booklets, so you'll see them in there. If they get to them, I thought there'd only be about 20 people, so I didn't think I would need to bring more. Again, we found one of the logistical issues was the transport, because the licensing laws for transporting participants had recently changed, and we found it was actually better to take the programs to where the people already felt safe, rather than try and get people to particular places for programs. And another big component of it was the peer engagement officers, who I think they're different terms used for the mentors. Our group chose to be called HOP Guides, and we ran a full day of training for them. Most of them came from the different organisations, and we wanted to make sure that everybody knew what it was they were selling, for want of a better word, to their clients. And I think it paid off that we did run that workshop, because of those who did better or best, this didn't include those who just turned up for the hop to good. If you have a look at the bottom two lines, the second to bottom one are people that it was one-on-one conversations with a hop guide. And the bottom one, which is also quite a lot, were people that I had spoken to at various events that we'd presented at. So in spite of the fact that every single organisation had done a massive amount of social media promotion, it was the one-on-one conversations that brought them in. Just so we responded whenever we could to the needs, so we changed some things. What was called safe-seated exercise didn't attract very many people, and we changed it to move to the beat, and then it increased. I went back in March, this is 2 years later, and interviewed a number of the stakeholders who had been involved in the program. And that saying some things change, some stay the same, sprang to mind. In Davis Park, they no longer have sausage sizzles. They now have a healthy one-pot cookathon every Friday, and they've put together a recipe book, and all the community members contribute towards that. We haven't solved all the problems of Davis Park, but they do have a day where they can get a healthy feed at least. Some of the other programs or partnerships that developed through the HOP continued for a period of time. The feedback I got, though, when I was there, that there was nobody there, there wasn't a dedicated paid coordinator anymore to deal with issues when they came up, and that did lead to some of them fading out because there just wasn't somebody to actually make it, make sure it happened. Everybody else had other priorities. 2 mental health organisations. The one has expanded massively because of an increase in funding, and another one is closed because of no funding. There's also a game, a health-promoting game, Bare Vein Bingo, which is, the catchphrase is living younger, longer, which is a game of bingo with pictures of things that'll help you live younger, longer. And that was very popular at the HOP, and I took that idea and I've developed it further into a health-promoting game that I presented at a conference in Singapore recently, and that's growing, so just watch this space. I might be presenting on it next year. Sorry, I haven't made any of those lovely QR codes, but if you would like to take a photo of that, or otherwise just Google Cockburn Integrated Health. The Cockburn Healthy Lifestyle Program continues, and that also, I think it epitomises what one of the speakers this morning was saying: when you work together, great things can happen. Thank you.
Thanks so much, Gillian. That was fantastic. Our next speaker is Johan. Oh, there we go. There we go. Thank you so much.
The big. Yeah. Okay, I have to go back. Okay. Good afternoon, everyone. My name is Johan. I am an associate professor in social work and social policy at the University of Antwerp and at Karel de Grote University of Applied Sciences and Arts. And I will be talking to you about a project I'm doing in collaboration with Emmaüs Vzw. Emmaüs Vzw, for the people from Flanders, might know it. It's a large organization in healthcare and welfare, about 7,000 employees, I think, across different sectors in healthcare and welfare. The theme of the project is how we are building an intersectoral approach to quality of care. Let me take you briefly to the outline of my presentation. I'm going to start off by briefly introducing the project, then going on to explaining you how we went about the construction of that intersectoral framework, moving on to how we made the connection between quality and reflexivity in a meta model that we use to put things in practice. And maybe if I have a little bit time left, and I'm looking at the chair then I will be able to give you the status presens of the project because it's still ongoing work. Okay, well, I don't think I have to really tell you this because you all know that healthcare and welfare organizations all over the world and also in Flanders are increasingly challenged on their quality. Are they delivering the quality that the people deserve? Are they effective? Are they efficient? And as a result of that challenge, a whole range of approaches are being developed on quality of care. Some of them are more quantitative. We measure quantitative indicators. Some of them are more qualitative. Some of them are extremely evidence-based scientifically. And others are more practice-based. And instead of choosing one of those approaches that are already existing, Emmaüs decided, I think 4 or 5 years ago, to develop their own framework for quality of care. The idea was not to build a system or a framework for quality of care for the different sectors, but an intersectoral framework for quality of care that overarches all those different sectors. The 4 partners of the project are on the slide. It's Youth Care, Emmaüs, and Betania Mental Health Care are the initiators of the project, I could say. And then Monnikenheide Spectrum, which is an organization that gives support to people with mental disability, and also a general hospital, St. Maarten. They jumped on the wagon on the way. So we have 4 partners now in the project. Unfortunately, one fell off the wagon, was a center for elderly care, due to circumstances, they had to quit the project, unfortunately. So there are 4 partners, and if I look at the general principles that we use, well, obviously the intersectoral focus I already mentioned. It's important that we try to develop something that can be used in the different sectors. And very important, we, as a methodology, or from a methodological point of view, we try to combine different sorts of knowledge. We try to combine knowledge of service users, which is very important to us, but also practical knowledge or practice wisdom of professionals, and of course also research-based knowledge or scientific knowledge. We use a bottom-up approach, we use participative methodology, and we try to co-create new knowledge. We try to do cooperative knowledge production, as Gillian and Sommerfeld call it. And in our effort to build this framework, the first thing we have to do, and the first thing we want to do, is create transparency. Transparency on what we think is important in terms of quality of care. And we want to do that in a way, and I think Bart it was that mentioned that healthcare and welfare are very complex situations. So we want to do it in a way that does right by that complexity. We don't want to just reduce it. We want to do right by it. Okay, so how did we do that? Well, first of all, and I really want to stress the importance of this preparatory phase. It was really a key element in the project. We started off in August 2020. We all know what went on then. I'll come back to that later. And basically, we call it, we cultivated the soil. We talk a lot in ecological perspectives. And we cultivated the soil basically advertising the project within the different partners' organizations. I don't think that it's a secret that quality of care most of the time isn't really sexy, hot topic for people on the floor. So we really had to make an effort, or we really made an effort to advertise our project. We used videos, we used posters, we used all kinds of flyers, and most importantly, we also visited all the teams, all the departments that were involved. They all got a kind of explanation what the project was. They were able to ask questions, and that was very important. We invited everyone to participate, and our slogan is and was, quality belongs to everyone, not only to a very small part of the organization, but everyone, all stakeholders. That means not only staff, professionals, but also service users. Yeah, well, we cultivated the soil and got people involved in our project. That was the first step. In a second step, we did our first part of research, you could say, and there was one general research question. What do service users, their social context, staff, and policymakers consider to be essential elements of quality of care? It's not that we didn't realize that there were already a lot of research projects that had asked this question, but it was really important in terms of getting people involved and keeping people involved, that we wanted to learn what they felt was important, what they felt was essential elements of quality of care. And we used a very broad participatory action research model with adapted methodology. And adapted methodology, well, I don't think that it's difficult to understand that if you want to talk to small children in youth care about quality of care, that you do that in another way than, for example, with policymakers or with the doctors in a psychiatric hospital. So we really used a whole range of methodological ways of raising data, collecting data. We used arts-based methods. We used also very boring interviews and focus groups. But we did all sorts of things. We did things with dance, with music, with images. And we also had to adapt our methodology to the situation because, you know, COVID, sometimes we forget that. But in that period, it was very difficult to get people together. So we also used phone interviews, we used surveys, we used all sorts of different methodology just to raise a huge amount of data, qualitative data, to answer the research question you all see on the slide. There wasn't really a theoretical framework that we used in the beginning. We used the grounded approach, as we call it, building from the empirical data. And obviously, it wasn't possible for me to do everything as the sole researcher. So there were a lot of people involved as co-researchers, and not only colleagues that are staff members, but also people with lived experience have contributed in many different ways as a co-researcher. So all the empirical data that were gathered that way were analyzed, were confronted with the scientific literature and also with policy documents, and that led eventually to this image. This is our framework for quality of care, which contains the essential elements which probably will be familiar. But this is not a model, this is not the model, this is our model. And everyone in the organization, the different organizations, participating organizations, they recognize this. This is our model. I don't have the time to go into detail, but at the center, there are the core values. If you talk about quality of care, it's always very important to start off with the core values and the common core values in different organizations. Then we have three concentric circles, micro, meso, macro level. Micro level where people meet each other. Meso level is the organizational level. Macro level is the societal level, obviously. And maybe there's one thing that I want to take out of the picture. Maybe you can notice it on the screen. You see these roots behind the image. This is our rhizome. We used rhizome theory. And basically, most of the time I use a metaphor to explain what is meant by that. It's our way to envision the complexity that I was talking about. And I think everyone knows a forest. Everyone goes for a walk sometimes in a forest. And if you walk through a forest, what do you see? You see trees, you see all sorts of things above ground. But what actually feeds that ecological system is below the ground, and that's the really important stuff. That's the rhizome, and it's the same, we think, within the world of healthcare and welfare. I see that I have used more time than I calculated for. So the next step was, okay, now we know what are the essential elements of quality of care, but what do we do with it? How do we use it to make practice more visible, more transparent? How do we embed those practices in a process of systematic quality evaluation? And we did that basically by making a link between quality and reflexivity. A common element in all organizations was that professionals most of the time reflect on what they're doing in some way. So we used that idea to open it up, and the core of the system is that we are going to, well, openly, intentionally, structurally, and ongoingly question what quality of care actually is, based on two important questions. Are we doing things right, which is a technical rational question, and are we doing the right things, which is a normative and ethical question. We started from that, and then this is the meta model we developed. It's pretty simple. You recognize the micro, meso, and the macro level, and basically the idea is that we use data on the essential elements of quality of care that we know, and we put that into this cycle. Yeah? And the first cycle is on a micro level, so that's on a team level, an organizational level. And for example, if you want to talk about participation, for example, we use the input from different perspectives. So we use the input from all stakeholders, that means professionals, but also service users, the family of the service users, etc. And we put them together into that first cycle, for example, about participation. So what is good at the moment? What can we do better? And we talk about it, and we try to find out how we can adapt the system within the organizations. That's at a team level. Sometimes that's enough. Sometimes we need the broader organization, so we go to a second cycle. And then that's on an organizational level, and then the same thing happens. And you also have a macro cycle, if possible, when, for example, funding or people from the government or so can be involved in the reflection cycle. I don't have much time to go into the details, but if someone has questions about it later on, maybe that's also a possibility. What are we doing now? Well, we're actually piloting this model in different organizations for the moment, in different themes. We're following that up with participatory observations, ethnographic research, and also interviews, trying to find out what are the critical success factors in this reflective approach to quality of care. We're almost finished, but it was a little bit too early to present that today, so I'm going to leave it at this, and thank you for your attention. Thank you.
Thank you so much, Johan. Our next presentation is from Michele Peters from the University of Oxford. Thanks so much.
There we go. Thanks for the introduction. I'm Michele Peters. I'm Associate Professor in Health Services Research at the University of Oxford. And as part of that, I'm a senior member of a research team for a policy research unit on quality, safety, and outcomes. So these are big collaborations between different universities, very multidisciplinary, where we effectively answer policy questions. And this one in particular looks at system-level research and answers. So I'll be talking specifically about the integrated care systems in England, where we've conducted quite a big study, but I'm focusing in on the progress towards forming new partnerships as part of these ICSs. So just to give you a little bit of background and what these structures are, so the whole health and social care and public health system has been restructured in England last year. So this was imposed on all the local areas. It only affects England, not the rest of the UK. And these 42 ICSs have been created, as you can see on the map. So they cover different geographical areas. and cater for the needs of the population of their specific area. So there are some differences. For example, you might have lower life expectancy or lower healthy life expectancy in the north in comparison to the south. So these ICSs are meant to address the needs for their own local populations. Each ICS operates at 3 different geographical levels. So you have the system level, which covers 1 to 3 million people, place level, and then the lowest level is the neighbourhood level, so the really local level, as you can see sort of depicted in the diagram. It varies how many places and how many neighbourhoods are in each of the ICSs, but I'll mostly focus on the top level ICS system. They're governed by an integrated care board that allocates the health budget and commissioned services. So that aspect is really focused on the health part. The integrated care partnership, on the other hand, looks at wider health and public health and social care needs. So bringing in local government together with the National Health Service, or NHS, that you've probably heard about. And they are developing and leading on the integrated care strategy. So this gives you a bit of an overview of what's happened last year. We conducted a study looking at how well ICSs are able to address quality, but what I'm talking about today is really looking at how these new partnerships are forming to develop the quality agenda. Very grateful to Johan for saying boring semi-structured interviews. That's what we used. When you're talking to senior system level representatives, it's quite a good pragmatic way of getting them on board. We asked them for an hour. Even that, with a lot of them, was a stretch. So we were lucky to involve the people that we did. We conducted the interviews online via MS Teams. They were recorded and then transcribed by a professional transcriber and analysed in NVivo using a thematic framework approach. Throughout the project, we had 2 patient advisors who worked with us. So they were part of developing the interview guide, setting up the study, and also involved in the analysis. Today, what I'm talking about is the baseline data, which we collected last year. We're just now finishing up collecting follow-up data, so we haven't analysed that yet. And just to point out, the interviews that we conducted was at a time when there was already a lot of activity at setting up these ICSs, but it was actually before they became legal entities in July. There were some delays with that. It should have happened earlier, but it finally did happen in July. So looking at the results, we had 4 ICSs that participated, very diverse in terms of their population, some smaller, some larger, also in different areas of England. We conducted 70 interviews, and you can see sort of the spread across it, a bit more focused on senior health representatives, but also quite a lot of people from the ICS executive team, so that ICB and ICP group. Local government representatives, so these would be people working in social services, and also the directors of public health services. And a number of patient representatives also took part. This was mostly Health Watch, which you may not have come across. This is a champion for health and social care users. So they sort of look at what is patients' experiences of care, and they speak up on behalf of the patient if something is not right in terms of how they're experiencing care. And I'll talk about the 2 main themes, setting up the ICSs and then looking in more detail about these emerging partnerships. So in terms of setting up these new systems, they all reported that progress was made. So they all sort of put a lot of energy into developing specific committees, so the ICB and ICP in particular, and also started filling a large number of new jobs and roles. And once this was a little bit more set up, then they started looking in more detail at their quality strategy. There was, of course, differences between these 4 different ICSs in how much progress they'd made. Progress was facilitated if they had a history of working together before. So some areas of England had already got other initiatives to integrate services more. So some of these had taken part in those and therefore had closer collaboration. So you can see that illustrated by the top quote. So they were already used to working together in that way. So it is easier to bring things together and learn from that. There were also a number of concerns. Obviously, it was quite soon after the COVID pandemic, so there was still a lot of mopping up happening from that. The second quote refers to that. So there were still really long waiting lists. They haven't really got any better with the strikes that we had this year. It's a different story. And there were also lots of concerns about the workforce. They were still very tired after COVID. There was a lot of shortages. Brexit comes into play with that. There's still lots of shortages of nurses, dentists, and so on. So there are problems with driving this forward. One of the aspects that they all agreed on in terms of emerging partnerships was that they needed good leadership. In terms of developing quality, but also just in terms of setting up these new entities. So the quality leads, the ICB and ICP people, they were all appointed. There were a lot of new people who came in with a lot of energy for driving change, sometimes from very different industries. They might not have worked in the health service before, but they really were breathing a new lease of life into the system. The key partners that were identified were effectively what was mandated. So to create these ICSs, these partners between health services, local government and patient representatives needed to work together. And this was really what they were trying to do in terms of creating them and driving the sort of collaboration forward. However, it's not so much in a way about who took part in it, but how well was it working. Well, we've already heard a lot about working in silos. They are maybe not working so much in silos anymore, so they're having more joint meetings, there's more communication, so there's good progress in that. However, in particular, when we talk to representatives from local government, also patient representatives, they pointed out that their voices were still less heard. So healthcare and health was really dominant, in particular the big hospitals. Their views were always taken on board more. Social care, public health was not listened to so much, and also the patient voice wasn't heard that much yet. They all agreed that the patient voice and their experience was really important, and they talked about co-production and about how they should consult patients, but it wasn't really happening apart maybe through HealthWatch, the health and social care champion. But they've thought, as again you can see in one of the quotes, that they would like the patient voice to be heard more and that it shouldn't just happen through HealthWatch. That is again an organisation, but maybe also talk to patients more themselves. There were a number of challenges. I think some people today have already talked around cultural differences. So there's differences in language between the different organisations. So sometimes they can't communicate in the way that they should. So they need to come together in that sense. And there are also concerns about balancing the hiring of new people versus having people there who know the history of the place and who understand the place. So that new energy versus the local knowledge, and how do you get that right? And broadly speaking, there was acknowledgement that although there was more collaboration, that it was not equal and that they needed to work on creating more equal partnerships. So for the discussion, I framed it according to a paper that was actually published just before we did this work around different components of leadership in integrated care systems. So this was before the ICSs were introduced, but it's quite useful to frame the findings. So one of the components of leadership for integration is inspiring the intent to work together. This was done very top-down. Obviously, the government decided that this was going to happen, but there was a lot of effort and energy put into it by the partnerships that were forming. Taking a wider view, yes, there were joint meetings fostering people working together, more communication, but the balance of the multiple perspectives was not quite there yet. So some awareness was there for cultural differences, but the language was still not common, and they still didn't take necessarily everybody's points of view on board. There was also awareness of power imbalances and some more commitment to be more collaborative, so giving more voice to these lesser heard groups. There was a lot of commitment to learning and developing. They were learning from joint history, so a couple of the ICSs that took part had a longer history of working together, of integrating health and social care, so they made more progress, and the other ICSs were very keen to learn from that so that they could also progress in the same way. And the last of the components around leadership was about clarifying complexity and developing policy. This was still quite early stage, but they were sort of starting to gain clarity about their approaches of how they were going to address quality and also setting their overall priorities. So just to conclude, it is possible to drive these very top-down decisions and to foster more integration at the system level and make these different people work together. But this is also where I would like to have Bart's slide on we need more time. When I saw that very important point. So progress is being made. However, there's time is needed to make it fully collaborative. But it's not only time needed for making it fully collaborative at the ICS level. The culture needs to change throughout so that the place-based level and the neighbourhood level also changes so that patients and their family members actually start seeing that there is a difference and that it's more integrated. It's not enough that there's more talk at the top level. It really needs to translate the whole way through. Thank you very much.
So I'm really quiet. So. Oh, good. Here we are. So thank you so much. I don't think we have times for questions for just now, but we have one more presentation, and then if I can get everybody we'll bring everybody up for a bit of a panel discussion. So thank you to Ross for coming up, and he'll speak to us about using integrative thinking technology. Thank you so much.
Thank you, Vicky, and thanks everybody for sticking it out to the end, and look forward to the conversation we have on the common themes and contrasts between these papers. You know, it's unusual to be thankful to go last, but in this case I am, because my colleagues from Toronto, Brianna and Grace, have kind of set the stage on Ontario Health Teams. I don't have to say too much detail about that, and Michele Peters' talk on the ICS systems and their evolution, early evolution in England, also sets the stage for some of what I'm going to talk about, which is really using the techniques of integrative thinking to explore and improve decision-making to create integrated care. So I'll say a little bit about the strategy around Ontario Health Teams, just to revisit that after 5 presentations since you heard about it. And really focusing in my talk on this challenge of bringing together people who may not have worked together previously, who hold different views about how the system should evolve, who have different values, different experiences moving forward, and then thinking about this technique, this set of tools around integrative thinking as a way to improve decision-making for these leadership groups. And an experiment that we carried out first stage experiment to use these kind of techniques with members of those teams in Ontario. So again, a little background here. There are more than 50 Ontario health teams. The number keeps growing, but some teams aren't fully approved right now. These are voluntary partnerships that will move towards some sort of formal organizational structure in the next year or so, funded by the Ministry of Health, but including in some cases care outside of healthcare to include social services as well. The government, in their wisdom, I think, not having a full idea of what the final structure would look like, in the province of Ontario, which is 15 million people, the largest province in Canada, but in a geography that is larger than the size of France and Spain put together, decided that they weren't going to mandate too many elements of this. They were going to let local groups decide what worked in those environments with the resources, the history, and the population that they had. So there were some funding given, I would say pretty minimal funding, but a lot of commitment, a lot of movement to try to redo our system and to move away from the siloed hospital-based system that's been typical of Ontario and, for that matter, much of the rest of Canada as well, to create something that is more in line with the population health thinking of the 21st century. And the way this will happen is through the development of care models for specific populations, and then that will translate eventually into care models for broader populations. Now, these Ontario health teams, or OHTs, all have created leadership groups, collaborative councils. You can see this orange square at the center of your screen, but some variation about the ways in which they engage with other members of the community, ways in which they involve partner and caregivers in their governance and leadership, and the ways in which they create structures that bring in other people who will be essential parts of the system. But structure is not the answer here, and although there's been a lot of work to try and change those structures over time to really reflect emerging needs, emerging issues, I think the key issue is around process. It's around decision-making at a leadership level as well as at a frontline level. And we know how challenging that is and has been in a number of initiatives, not only in healthcare, but in many different other industries. And so John Kanya and Mark Kramer, in their initial paper on collective impact, talked about the importance of effective decision-making if you're going to have the ability to make an impact as a voluntary partnership moving forward. And another quote here from Anne Volstead, building on work by Crutchfield and Grant, to talk about the challenge of bringing people together to work effectively in these partnerships, knowing that every organization typically has its own view of the world, its own goals, its own structures, but that the most successful partnerships are ones where there can be a common understanding of what the vision is, what the strategy is, and how to achieve it. So it's all around decision-making at a leadership level, and as I suggested, at other levels of these partnerships as well. And there's an enormous literature on decision-making in the academic world, and there's also a lot of things written to be helpful for people who are in leadership roles to understand how to be better at making decisions. And this is just some of the principles that you see here. And they're hard to disagree with. It's all very straightforward, right? But in practice, it's very challenging moving forward. And I'm working with a team at the University of Toronto. My co-leaders in this team, Paula Blackstein-Hirsch and Michelle Nelson, and I have run a series of programs around leadership for the OHT leaders and for the coaches that work with these OHT leadership teams. And we've been sensitized to the challenges that these leaders face moving forward. Because although it looks fairly simple from 30,000 feet, in fact, we brought together people who have very different experiences in an evolving system with different values and different ways of imagining and working on the future. So healthcare is complex. It is challenging. It's moving fairly quickly in Ontario as it is elsewhere. And people's prior experience and values make a difference moving forward. How do we create an environment where we can make effective decisions in that way? Now, as part of the advanced work, we collected materials on the leadership structures and decision-making processes of leadership teams. We got about 21 sets of materials from these teams, of the roughly 50 now in existence. And not surprisingly, because the ministry had urged them to act in this way, almost everybody said that the method of making decisions was based on consensus, which is a great thing. However, in practice, they also gave themselves a number of outs if you couldn't reach consensus. And as we all know, when the stakes are high and the experiences are different, that consensus can be quite challenging. And so this is the environment we're in. Everybody would like to agree on what we need to do, but in fact, the reality is it's sometimes very challenging to get there. Well, luckily, we have some really useful work by Roger Martin and Jennifer Reel, who in these books, Creating Great Choices, and Roger's earlier book, The Opposable Mind, suggests that there's ways in which groups can be much more effective in making decisions of the kind of complex questions that are facing all leadership groups, not just healthcare groups, but all leadership groups in the current environment. And we often see leadership groups making decisions with a really short span of analysis, or even when there's a longer analytical period, the end result is often the choice of the best of a series of not great alternatives. And so Roger and Jennifer said, we need to go beyond consensus. We need to think about ways to create great choices and not just choose the one that's least offensive to us. So this is the quote from Roger Martin. He says, integrative thinking is the ability to face constructively the tension of opposing models, and instead of choosing one at the expense of the other, to create a creative resolution of the tension in the form of a new model that contains elements of the individual models, but is superior to each. Now that's a great and a lofty goal, but I know many of you are now thinking, well, yes, that's fine, but how do you do this realistically? One of the issues here is to recognize that it is possible to do this, and I'll say a little bit more about what the techniques are. It's in 4 stages. Here, first of all, is the articulation of models, and in particular, identifying the key characteristics of them. I try to make these as radical choices moving forward. Then examine these as a leadership group to define the tensions, the assumptions, and the cause and effect, what things are moving these decisions. Explore those possibilities to create a new model that borrows elements from these existing models, and then develop prototypes and test them moving forward. And that's what we did in a sort of a test case, an integrative challenge for Ontario health teams in the area of the modernization of home and community care. And this has been a challenging issue in Ontario for, frankly, a couple of decades right now, and a variety of structures and approaches to this. And the government is creating new legislation. But the question is, how should this home care modernization really be done in the environment where we're moving towards integrated care models? And 2 specific models were identified moving forward. One of them, which has been labeled the neighborhood model, says that we put home care providers in specific neighborhoods. And this creates the opportunity to be closer to the clients, to the customers of home care. It also creates a potential bonding among clients who have similar kinds of issues in that neighborhood, and improves efficiencies so that the providers don't have to move around a lot. And the second model is the one care team model, where we attach the home care staff to the primary care practices that exist in that environment. Now, one challenge in Ontario is that not all those environments have team-based primary care, but in places that do, this is a very appealing model to think about home care being linked to the knowledge base of primary care and the opportunity to share insights and updates from among these staff. Now, the approach that Josie Fung and her team at the Pivot Group, who we worked with on this project, have is to start by really mapping out these models, the characteristics of these models, I won't spend a lot of time doing this. I've talked about some of the high-level details. And then to see the models through the eyes of different stakeholders who have a asset that they want to mold to the right effect for themselves and for the clients. So you can see this sort of one-by-one step of identifying the stakeholders and identifying what the benefits are for those particular stakeholders. And you might ask this question, so why do we focus only on benefits and not on disadvantages? And it brings to light a critical element in this approach, which is to say, most of the time when we think about options, we think about pros and cons. But Jennifer and Roger, working with their teams, have said, we want to focus on benefits for two reasons. One of them is the identification of things that emerge from different models that would be useful in a final model, so helping to construct this where possible. And the second is to create a collaborative environment where people now see the benefits in models that they wouldn't naturally support moving forward, to give them the opportunity to now create a new model together. And the answer to the pro-con approach is the pro-pro chart, where we talk about what different stakeholders want from different models, and to use this as a basic first step in understanding what might be possible moving forward. And then we reflect on this, and we try to identify the things that are of value, try to identify the things that we might not actually want to do, but we could live with in order to do some elements of a combined model. So in our experiment with the groups moving forward, we tried to do this in a very detailed way. We were challenged a bit because we were doing it in a virtual environment. And we didn't get to the point in which we could say we had all the elements of that model. But we saw some things that are reflected in some of the insights that Josie and her colleagues have told us about. This idea about really getting to know these models well, seeing the tension between the models as an opportunity, not just as a challenge. Many times when you have alternative models, people want to just dump on one model because they're really favoring a second model. So you're kind of playing with these different options. And drawing from the perspectives of others, the different experiences, characteristic of leadership groups in Ontario health teams. So I don't think we got as far as we wanted to in our initial experiments, and I've given you some feedback here from the workshop participants. Many people are very excited about this opportunity moving forward, and we're now going to work to create a stronger facilitative structure to work with our teams in order to create an environment where we can develop some models that might be possible to test in different environments. I'm over.
Thank you, Ross. As you all can see, it is 4 o'clock, and our session has come to an end. Many of you have put questions in the app, and I would invite our presenters to please respond to the questions. So each presentation has questions. If you could please respond and share, that would be great. In summary, Vicky and I would like to thank the presenters, and to end a session when we're talking about integrated care with the opportunity in front of us with integrative thinking and with opposing ideas to come up with integrated models that we can deliver on, but also shift the mindset, behavior, and experience for all of us, is a profound ending for an incredible presentation from everybody. So thank you on all of our behalves. We welcome you to shift to your next presentation. The next one start now and go until 6 o'clock. Thank you, everyone. It was extraordinary. Vicky, it was wonderful to co-chair with you.